أحب أهني زملائنا وإخواتنا في البيدياتريك نيورولوجي كايرو يونيفرسيتي على المؤتمر الجميل ده والبروجرام الأجمل وفيري يعني very nicely put. أنا بشكر أستاذ الدكتور إبراهيم شكري، أستاذة الدكتورة لبنى منصور، أستاذة الدكتورة أمنية عفيفي على دعوتي، ودكتور بيومي غريب، وحبيباتي الدكتورة مريان ودكتورة ولاء النجار طبعا رفيق المؤتمرات دكتور عمرو غنام ودكتور عريف. فالواحد حاسس ان هو في بيته، فالف مبروك لكم وان شاء الله دايما موفقين. It's my pleasure to introduce Professor Dr. Marian Yousry, presenting the role of EEG in diagnosing different epilepsy syndromes.
Thank you, Professor Hoda, for the introduction. Actually, it's an honor to present in front of such elite professors. And I will talk on the EEG. معذرة دكتورة آن، حضرتك تسمعيني في EEG، حضرتك أستاذتنا فيه طبعا. My talk will be about the role of EEG in diagnosing various epilepsy syndromes, and I will try to make it more interactive to be interesting. How? لا أنا عايزة العكس. هي هنا. لا هي هنا الأول.
البرزنتيشن دي.
الليكتشر الأول بعد كده مش بتقلب ليه؟ لا هاتوا من الأول من فضلك. يس من هنا هنا وده بيقدم ده بيأخر. Of course, we all know that there are different EEG patterns that point out to various epilepsy syndromes. According to this paper from the International League Against Epilepsy, published in Epilepsy in 2022 by Specchio and his colleagues, about the classification of epilepsy, and they classified epilepsy into self-limited focal epilepsies, including select, Celius, Cove, and Paul, and the genetic generalized epilepsies that constitute childhood absence epilepsy, epilepsy with eyelid myoclonia, epilepsy with myoclonic absence, and the DEEs including Dew's syndrome, which is epilepsy with myoclonic-atonic seizures. This diagram shows the genetic generalized epilepsy syndromes, which constitute the childhood absence epilepsy, epilepsy with eyelid myoclonia, epilepsy with myoclonic absence, epilepsy with myoclonic-atonic, and it is considered one of the DEEs, and they have all genetic etiology, positive family history, their cognition and neurological examination is variable, they have classic seizure semiology and specific EEG features. I'm going to present my first case. This was a girl, 3 months old infant, presenting with attacks that resemble infantile spasms. The child had normal development with no risk factors, and the development remained normal even after the spasms. EEG done interictally is normal. First question to you, the EEG request should be done during wakefulness and sleep, during sleep only, during wakefulness only. مش هقدر ادخل المنتيميتر هنا دلوقتي ولا هينفع ولا لا؟ عشان بس وقت المحاضرة ولا اكمل؟ You can just do www.mentimeter.com and you can use the QR code or use this code 729-46119. No. This is the QR code. You can scan the QR code. Two chose EEG wakefulness and sleep. One chose EEG wakefulness. We want more choices, please. QR code. Okay, most of you have chosen EEG wakefulness and sleep. Why do we choose wakefulness and sleep? Because I'm sorry for this delay. مش عارفة ماله مش بيقلب ليه. Time is running and I will go short of time. No. اللي قبلها. Why? Because we are searching for HIPS arrhythmia that begins, usually it appears during the non-REM sleep or with awakening. Also, we are searching for epileptic spasms that are frequently observed after awakening. See this video. This infant has been to many doctors and they have prescribed anti-epileptic. What's your opinion regarding the diagnosis? Infantile spasms or not infantile spasms? Not infantile spasms. طب what is it? هتكون ايه طيب? This is not, of course, not infantile spasms because of many reasons. First of all, that the development remained normal even after the spasms, and it is not typical, the phenomenology is not typical of the spasms. It might be benign myoclonus of early infancy. It was first described in 1976 by Fegerman. He described it in 10 patients, and he put them on EEG that showed that there is no ictal EEG discharge. This is a non-epileptic paroxysmal phenomena that occur in healthy children during the first year of life and usually disappear within the second year of life. This is the ictal EEG record. The ictal EEG record this is the EMG showing the muscle contractions with no corresponding ictal EEG epileptogenic activity. of course denoting that it is not epileptic. What about this? This is the EMG record of, this is typical infantile spasms. You can see here the rhomboid appearance or the diamond-shaped appearance seen in the EMG during the spasms. This is very characteristic, and of course with a corresponding burst suppression pattern. What is the difference between West syndrome and benign myoclonus of early infancy? West syndrome can occur during wakefulness and during sleep. However, benign myoclonus only occur during wakefulness. The EEG in West syndrome almost always abnormal if it is done in the correct time. As I said, during sleep and during wakefulness. However, benign myoclonus of early infancy have normal EEG. The psychomotor retardation always present in West syndrome, never present in benign myoclonus. And both of them might have features like myoclonia, spasms, brief tonic contractions, and they might occur in clusters, where also several fits can occur in several fits per day. In cases of West syndrome, key points during recording. First of all, you have to do polygraphic. Polygraphic means that it is better to put the EMG electrodes with bilateral EMG on the deltoid muscles in order to point out the rhomboid appearance that I showed. With non-REM sleep and 15 minutes after awakening, the best time to do the EEG. Awake EEG could be normal and not showing hips arrhythmia. Another differential diagnosis to this case is a benign condition called tonic reflex seizures of early infancy. Actually, it is present at the age of 2 to 3 months and triggered by tactile proprioceptive stimulation. زي حد هشكه أو during change of the posture. الأم شايلاه وبعد كده رجعته على السرير فيبدأ يعمل بالظبط زي ما الفيديو ده عمل contractions, extension و abduction of all 4 limbs together with apnea and cyanosis, and the child usually cries for few seconds after the attack, and these attacks disappear by the age of 4 to 5 months. And this patient, of course, should not be given anti-epileptic. Case 2 is a 10-month-old boy, normal development. He had myoclonic jerks with occasional drop attacks at the age of 8 months. The development remained normal. Clinical examination and MRI is normal. No other seizure types are observed. This is the EMG showing the myogenic contractions, the muscle contractions, and you can see that there is corresponding generalized polyspike wave discharge, meaning that these attacks are epileptic. Question number 1, is this drop attack due to the myoclonic jerk or due to atonic fit? As we can see in the EMG, this is due to the myoclonic jerks because they have muscle contractions on the EMG. Does this scenario fit into a specific syndrome? The child have only myoclonic jerks only, with no GTCs, with nothing, and his development is near normal. Yes, this is myoclonic epilepsy of infancy. Are you going to treat this case with anti-epileptics? Yes, because it is epileptic. What is myoclonic epilepsy of infancy? The age of onset from 4 months to 3 years, myoclonic seizures is the only type of seizure. And they are frequently asynchronous. Seizures occur during wakefulness and drowsiness, and during the ictal records, you have an ictal EEG polyspike wave discharge. Another case is a 3-year-old child presenting with myoclonic jerks followed by falling down. And this is his EEG. As you can see that there is myogenic activity followed by myoclonia-atonia, myoclonus atonia. There is complete absence of activity here, what we call negative myoclonus. Correspondingly, this is concordant with the myogenic contractions, concordant with the polyspike, and the slow wave concordant with the myoclonic-atonia. So the EMG correlate is a burst of myoclonic jerks post-myoclonic-atonia, and the myoclonic jerks are time-locked to the spike wave. I will show this in this video. It is very prominent here. Okay. This video from the International League, and it is free to download. Look on the EMG, there is the myogenic contraction followed by post-myoclonic-atonia, and this is time-locked with the generalized polyspike followed by the slow wave which correspond to the myoclonic-atonia. The interictal EEG showing theta rhythm. What is this syndrome? This is, of course, Douce syndrome, myoclonic-atonic epilepsy. Douce syndrome is put here in the classification in the DEEs as one of the genetic generalized epilepsy. The age of onset is from 1.5 to 5 years. We have the myoclonic-atonic fits as well as GTCs, and both of them might occur at the same time. And the onset might be very stormy. Occurring, the GTCs might occur up to several times per day. It has a genetic etiology, and one of its genes is SLC2A1, which is glucose transporter defect gene. In 5% of the cases, you have to look for this gene because it has a specific treatment, and it is a self-limited condition. It stops within 3 years in 2/3 of the cases. Another case. Look at this girl. The paroxysm. When does the paroxysm occur? When she closes her eyes. I will show the video again. Okay. The EEG on eye closure, it appears on eye closure, completely disappear on eye opening, and then it reappears on eye closure again. This is a video of one of my cases. She was complaining of some semiology, so I've just let her look at the light, and these are the characteristic phenomenology or semiology of these seizures. What are this? What is this syndrome? Huh? Yes. This is epilepsy with eyelid myoclonia, EEM or Jeavons syndrome, and it is here in the classification. It is not a DEE. Epilepsy with eyelid myoclonia is characterized by upward deviation of the eyes. The eyes have to go up with jerking of the eyelids together with head extension, often precipitated by two things: closing the eyes and light exposure. Eyelid myoclonia may be associated with absence or maybe not. Jeavons syndrome is a triad of eyelid myoclonia, eye closure-induced seizure or eye closure-induced EEG paroxysm, what we call fixation of sensitivity. يعني on eye closure ال EEG بان، أو on eye closure ممكن الأتاك تظهر، و photosensitivity triggered by intermittent photic stimulation. طبعا ال intermittent photic stimulation may precipitate an attack. So when you request the EEG, you have to request it on eye closure and eye opening in illuminated and in dark room. I know that Dr. N does this. Intermittent photic stimulation has to be done, and it should be done at the end of the record because the patient can have an attack, can precipitate an attack. Look at this girl. What is she doing? Staring, associated with this movement, myoclonic jerks, what we call going upwards like that. Myoclonias occur at the same frequency as the spike wave. You see the EMG, it has a specific pattern, periodicity. It is the same logged in with the epileptic EEG activity, 3 cycles per second. What is this syndrome? This is epilepsy with myoclonic absence. Epilepsy with myoclonic absence, EMA. Epilepsy with myoclonic absence اللي هي الفينومينولوجي اللي شفناها دي exclusively is observed in this syndrome only. It is not observed in any other epileptic syndrome. The myoclonias are constantly predominant in the proximal limbs, giving what we call the ratcheting appearance or تصاعدي myoclonic jerks تصاعدي ايديها تترفع لفوق rarely involving the face. Of course the eye involvement is typically absent because I want to exclude epilepsy with eyelid myoclonia. Like typical absence, the EEG is typical 3 cycles per second and it is time locked with the myoclonic jerks. Okay, another case is an 8-year-old boy, completely normal, presented with attacks of GTCs. The parents noted also staring of sudden onset up to 5 to 6 times per day. These attacks were exacerbated with photic stimulation. No myoclonic jerks were noted even on awakening. This is his ictal recording. What do you see in this ictal recording? Paroxysmal discharge of spike wave complexes at a frequency of 3 to 3.5 cycles per second. So it is faster than what we see in childhood absence. And خلينا العيان ينام. حصل ايه هنا؟ هنا sharp slow over only the frontal regions. This is so confusing because you might تقدر يعني ممكن تفتكرها انها focal epileptogenic activity. لكن هي لا. ليه لا؟ لأنه اللي بيحصل هنا fragmentation of the EEG. What is this syndrome? Juvenile absence epilepsy, and according to Hirsch et al., juvenile absence epilepsy is considered one of the idiopathic generalized epilepsies, which برضو is a part of genetic generalized epilepsies. أنا محتاجة وقت تاني معلش عشان أنا ضيعت وقت في المنتيميتر ده. Juvenile absence epilepsy البيك ايج بتاعه 8 ل 13 فممكن ال 8 دي تبقى overlapping مع ال childhood absence. Absence seizures mandatory. It has to be present. Generalized tonic-clonic seizures occur in more than 90% of the cases. The interictal EEG is a paroxysmal discharge at a frequency of 3 to 4 hertz, and the sleep EEG might be fragmented. Fragmented generalized spike waves, you see here that the focal discharge is not consistently present in one area. ده بيتنقل. والحاجة الثانية المورفولوجي بتاع الفوكال ديشارج شبه الجنرالايز سبايك ويف. فهي جزء من الجنرالايز سبايك ويف بس بيبقى fragmented during sleep. طيب هو ليه أنا مهتمة قوي إن أنا أفرق الشايلدهود absence من الجوفينايل absence؟ because juvenile absence is a lifelong therapy. يعني ده عيان ما يتوقفلوش الانتي ابيليبتكس خالص. طيب case 7. This is an 18-year-old boy with history of GTCs and myoclonic seizures. Ictal EEG showing generalized polyspike wave discharges with bilateral symmetrical limb jerks. This is the ictal EEG. During the myogenic activity, you have the polyspike wave discharges. And he only presents with GTCs and myoclonic jerks. What is this syndrome? The age and the EEG pattern goes with juvenile myoclonic epilepsy, JME. And in this juvenile myoclonic epilepsy, the onset is from 10 to 24 years. Usually it might 15% منهم evolving من childhood absence. Myoclonic seizures typically occur في حالتين, on awakening and when the child is tired. And they are mandatory for diagnosing juvenile myoclonic epilepsy. Photosensitivity can occur in 90%. And sometimes the myoclonic jerk precedes the generalized tonic-clonic, what we call myoclonic-tonic-clonic, وده phenomena يعني term صح وموجود. Absent seizures occur in 1/3 of the cases. ال EEG interictally 3 ل 5.5 وبرضه they often fragment the generalized discharge fragment during sleep وفي photoparoxysmal response. طيب requesting the EEG امتى؟ requesting the EEG when the child is tired and on awakening الصبح بدري. Case 6 دي آخر حالة. 6-year-old boy presented with attacks of unilateral numbness, paresthesia في tongue, lips and gums with orofacial motor signs in the form of tonic-clonic contractions of one side of the face, mouth and tongue, followed by speech arrest occurring only during sleep. And the EEG, the awake record show the focal epileptogenic activity. Yes, The EEG report came out to be like that. Epileptiform activity characterized by stereotypic high amplitude, sharp slow wave complexes localized in the centrotemporal region, unilateral but more often bilateral, occasionally in awake and increased during non-REM sleep. This pattern is highly suggestive of benign childhood epilepsy with centrotemporal spikes. Do you agree with this report or not? لو شلنا الفينومينولوجي اللي في الأول اللي أنا قلته في الأول وحطيت لكم بس ال EEG وحطيت لكم الريبورت ده هتوافقوا ان this pattern is highly suggestive of benign childhood epilepsy with centrotemporal spikes اللي هو Rolandic epilepsy. ارجعه حاضر. اي دكتور وائل ليه؟ ما هي centrotemporal spikes فعلا، بس هل هي suggestive of benign childhood epilepsy with centrotemporal spikes? What I want to say here that there are different epileptic syndromes with similar EEG pattern. You can have this scenario of a 3-year-old patient with global developmental delay, microcephaly with typical washing hand posture, as my professor Dr. Lobna mentioned, and Rett syndrome in stage 2 might have centrotemporal Rolandic spikes. So when you see a centrotemporal Rolandic spikes ما تقولش على طول إن هي benign childhood epilepsy with centrotemporal spikes, because it might occur in many other syndromes like Rett syndrome and like this boy. This boy is coming for learning difficulties and his EEG showing also Rolandic spikes. And this boy is severely mentally retarded. This is Fragile X syndrome وبرضه موصوف فيهم centrotemporal spikes أو Rolandic spikes. In summary, video polygraphic EEG is a very gold standard in reaching the diagnosis in various epilepsy syndromes. شايفين حضراتكم ال EMG picture time locked مع ال ictal EEG discharges قد ايه ساعدتنا في الديagnosis. Taking a good history and defining seizure semiology, agent of onset and developmental history before and after the seizures is mandatory to reach a proper diagnosis. Thank you very much.
Thank you very much, Professor Marian, for your excellent illustrative presentation.